35-year-old Adam is brought to the emergency department by an ambulance after being involved in a motor vehicle crash. Upon examination, you notice that he is significantly bleeding from his thigh, so you decide to give him a blood transfusion. 5 minutes later, he develops shortness of breath, one episode of non-bloody vomiting, and a diffuse rash with erythematous borders starts to appear all over his body. Also, his blood pressure drops to 60/40 millimeters of mercury. Some days later, you see 50-year-old Jack, who's complaining of fever, malaise, and a decreased production of urine for the past 2 days. On further questioning, Jack tells you that he underwent a kidney transplantation 1 month ago. Upon examination, you realize that he has high blood pressure, 150/80 millimeters of mercury. You decide to perform a biopsy of his transplanted kidney, which reveals a dense lymphocytic infiltrate. Okay, based on the initial presentation, Adam seems to have some form of blood transfusion reaction, which includes any adverse event that occurs following blood transfusion. Jack, on the other hand, seems to be experiencing some form of transplant rejection, which is when the immune system of the recipient attacks the transplanted organ or graft. All right, let's start with blood transfusion reactions. For your tests, there are 6 blood transfusion reactions that you need to be aware of, including anaphylactic or allergic transfusion reaction, acute hemolytic transfusion reaction, delayed hemolytic transfusion reaction, febrile non-hemolytic transfusion reaction, transfusion-related acute lung injury, and transfusion-associated circulatory overload. Let's begin with the anaphylactic or allergic transfusion reaction. It is a type 1 hypersensitivity reaction mediated by the recipient's IgE antibodies against plasma proteins like immunoglobulins found in transfused blood. Initially, the proteins in the donor's plasma will be recognized by preformed IgE immunoglobulins present on the surface of mast cells, which in turn release their granules containing inflammatory mediators, such as histamine. As a result, within seconds or minutes of starting the transfusion, the recipient develops urticaria, which is a raised, pale rash with erythematous borders, accompanied by pruritus or itching, and fever, as well as wheezing or a whistling sound in the chest, hypotension or low blood pressure, which can potentially progress into respiratory arrest, meaning the individual may stop breathing, as well as anaphylactic shock, which is when the blood pressure is too low to maintain adequate tissue perfusion. Sometimes, though, symptoms start 2 to 3 hours after the transfusion, as more time is needed for the mature plasma cells to be formed and produce IgE antibodies in response to the foreign plasma proteins. What you definitely need to know for your exams is that anaphylactic transfusion reaction commonly occurs in individuals with IgA deficiency because they have anti-IgA antibodies, and IgA is found in most blood products. So bear in mind that individuals with IgA deficiency should receive washed blood products from which IgA immunoglobulins have been removed. Next is acute hemolytic transfusion reaction, which is a type 2 hypersensitivity reaction, where the recipient's preformed antibodies attack the transfused red blood cells. This transfusion reaction typically occurs because of an ABO blood type incompatibility. Now, the ABO system refers to the type of glycoproteins found on the surface of red blood cells. So you can either have type A, type B, type AB, or neither, which is called type O blood. The immune system produces antibodies against the glycoproteins that you don't have. People with type A blood have antibodies against type B glycoproteins, and vice versa, while those with type AB blood don't have antibodies against any red blood cell glycoprotein. And finally, people with type O blood have antibodies to both A and B glycoproteins. Now, as an example, if a recipient with type A blood is given a transfusion from a donor with type B blood, the recipient's immune system will attack the donor blood, leading to intravascular hemolysis, or red blood cell destruction within the recipient's blood vessels. Symptoms of acute hemolytic transfusion reaction can begin during the transfusion due to the presence of preformed antibodies, or any time within 24 hours from the transfusion, which is the time it takes plasma cells to form the antibodies. Individuals who have acute hemolytic transfusion reactions may experience fever, hypotension, tachycardia, and tachypnea. Now, acute hemolysis results in a massive release of hemoglobin into the blood. Some of this hemoglobin breaks up into heme and globin. Heme is then converted into bilirubin, leading to hyperbilirubinemia, or high bilirubin in the blood. As a consequence, individuals may present with jaundice, which is when the excess bilirubin deposits in the skin and eyes, causing them to turn yellow. On the other hand, some hemoglobin can reach the kidneys to be excreted in the urine, which is known as hemoglobinuria. As a result, individuals with acute hemolytic transfusion reaction may present with red urine associated with flank pain. In addition, free hemoglobin is toxic to the kidneys and can cause acute renal failure. Now, there's also delayed hemolytic transfusion reaction, which is when hemolysis starts after 24 hours of transfusion, generally within 1 to 2 weeks. This typically occurs when there are antibodies against minor antigens on the donor blood, such as rhesus or Rh. Now, people are either Rh positive, meaning they have the Rh protein on their red blood cells, or they are Rh negative, meaning it's absent. So if an Rh negative person receives Rh positive blood, they could develop a delayed hemolytic transfusion reaction. Now, keep in mind that this reaction results from an anamnestic response, meaning that to develop a response, the recipient must be previously exposed to these minor antigens, like by a prior transfusion or pregnancy, which led to the development of antibodies without causing a noticeable reaction. On a subsequent exposure, like a later blood transfusion or a second pregnancy, these antibodies will be ready to trigger an intense immune reaction. Now, in delayed hemolytic transfusion reactions, the antibodies don't directly destroy the donor's red blood cells, but rather mark them for destruction by organs of the reticuloendothelial system, meaning the spleen and liver, resulting in extravascular hemolysis. Individuals with delayed hemolytic transfusion reactions are often asymptomatic, while some may experience self-limited symptoms, such as a mild fever and jaundice. All right, next up is febrile non-hemolytic transfusion reaction, which is more common in children for unclear reasons. Now, as the name implies, this reaction doesn't cause red blood cell destruction, and it mainly manifests as a fever following blood transfusion. This occurs due to the release of inflammatory mediators like cytokines from white blood cells in donor blood. Another proposed mechanism for febrile non-hemolytic transfusion reaction involves a type 2 hypersensitivity reaction, where antibodies in the recipient's blood target human leukocyte antigens, or HLAs, on the surface of the donor's white blood cells. This again causes these cells to break and release their cargo of cytokines into the blood after transfusion. In both cases, the released cytokines put the body in a state of heightened immune response, like when you have a cold. Symptoms of febrile non-hemolytic transfusion reaction usually start within 1 to 6 hours after transfusion and include fever, chills, headache, and flushing, which is a sudden reddening that usually involves the face and neck. Febrile non-hemolytic transfusion reaction can be prevented by a process called leukoreduction, where white blood cells are removed from blood prior to transfusion. And that's a high-yield fact. Another blood transfusion reaction you should know for your exams is transfusion-related acute lung injury, or TRALI for short, which is the #1 cause of death among all transfusion reactions. TRALI can start within minutes to 6 hours after blood transfusion. The underlying mechanism of TRALI can be best explained by the 2-hit model. The first hit occurs before the transfusion process, when any stressor, like sepsis, shock, or trauma, causes neutrophils in the blood to be recruited and sequestered in the pulmonary capillaries. These stressors also cause the neutrophils to be primed, meaning they're prepared to start an inflammatory response when there's another stressor, or second hit. In TRALI, the second hit is the transfusion itself, where antibodies in the donor's blood activate the primed neutrophils, giving them the signal to start an inflammatory response in the lungs. Neutrophils then respond by releasing inflammatory mediators like cytokines, proteases, oxidases, and reactive oxygen species. This in turn will increase pulmonary capillary permeability, leading to fluid accumulation in the lungs' interstitium. As a result, individuals develop non-cardiogenic pulmonary edema, which is when the fluid accumulation is not due to cardiac causes like heart failure. And that's an extremely high-yield fact. In addition, the pulmonary edema is associated with respiratory distress, which is characterized by dyspnea, or shortness of breath, and tachypnea, or rapid breathing. Also, individuals with TRALI may experience fever and hypotension, or low blood pressure. Now, a similar blood transfusion reaction is transfusion-associated circulatory overload, or TACO for short. All right, the thing is, all blood products are packed in fluid, and therefore a potential complication of transfusions is fluid overload. In a test question, look for an individual who has congestive heart failure or chronic kidney disease and presents within 6 hours of the transfusion with respiratory distress and cardiogenic pulmonary edema. The treatment for both reactions is different as well. The main treatment for transfusion-related acute lung injury is respiratory support by delivering supplemental oxygen, while treatment of TACO includes the use of diuretics in addition to supplemental oxygen. All right, let's switch gears and talk about transplant rejection, which is when the recipient's immune system attacks the transplanted organ. For your tests, you need to know that there are 3 types of transplant rejection based on their rapidity of onset. These are hyperacute transplant rejection, acute transplant rejection, and chronic transplant rejection. Okay, let's start with the hyperacute transplant rejection, where hyperacute indicates that it starts within minutes from introducing the organ into the recipient's body. It's a type 2 hypersensitivity reaction, meaning it occurs when the recipient's blood contains preformed antibodies that bind to the transplanted organ or graft. This leads to the activation of the complement system, which normally helps the immune system destroy foreign bodies like pathogens. So, complement activation results in a strong inflammatory response against the graft. In addition, these antibodies also bind to the endothelial cells within the graft's blood vessels, inducing platelet aggregation. This results in widespread thrombosis, or clotting within the graft, which ultimately becomes ischemic and necrotic. Keep in mind that hyperacute transplant rejection can be life-threatening, and the only treatment involves prompt graft removal. Next is acute transplant rejection, which usually develops weeks or months after the transplant. This begins when the recipient's CD4 T helper cells directly recognize the major histocompatibility complexes, or MHCs, on the graft cells. The CD4 T helper cells in turn stimulate CD8 cytotoxic T cells to attack and destroy the graft's cells. So this is a type 4 hypersensitivity reaction. In addition, T helper cells stimulate B cells to start producing antibodies that bind to antigens on the graft cells, initiating a humoral immune response. So this is a type 2 hypersensitivity reaction that's similar to a hyperacute transplant rejection. However, an acute transplant rejection takes longer to develop because there are no preformed antibodies, so they're produced after the transplant takes place. Upon histology, some high-yield findings that you could see include dense interstitial lymphocytic infiltrate in the graft's tissue, as well as vasculitis or inflammation of the graft's blood vessels. Symptoms of acute transplant rejection include fever and malaise, as well as specific symptoms related to the transplanted organ. For example, individuals with acute rejection to kidney transplant would also have oliguria, or low urine output, as well as peripheral edema, or lower leg swelling, and hypertension, or high blood pressure. Treatment and prevention of acute transplant rejection involves the use of immunosuppressive therapy. Now, the last transplant rejection reaction that you need to know for your tests is chronic transplant rejection. This type of transplant rejection can develop months or even years after the transplant. Now, similarly to acute transplant rejection, chronic transplant rejection is mediated by a combination of type 4 and type 2 hypersensitivity reactions. However, in chronic transplant rejection, the MHCs and other antigens on the graft cells are first recognized and captured by the recipient's antigen-presenting cells. The antigen-presenting cells then present the graft antigens to the recipient's CD4 T helper cells. Finally, T helper cells activate CD8 cytotoxic T cells and B cells, triggering a gradual immune response that ultimately damages the transplanted organ. Upon histology, some high-yield findings include abnormal thickening of the graft's blood vessels due to proliferation of the vascular smooth muscle. In addition, there's parenchymal atrophy, or loss of functional tissue, together with interstitial fibrosis or tissue scarring. Now, examples of chronic graft rejection include chronic allograft nephropathy, where the function of a transplanted kidney declines over time, as well as bronchiolitis obliterans, which occurs when bronchioles in the transplanted lung obliterate or become progressively damaged due to inflammation, which ultimately results in fibrosis. Chronic rejection can also occur in a transplanted heart, which manifests as accelerated atherosclerosis, where fatty deposits or plaques build up inside the coronary blood vessels and may put the individual at risk for coronary artery disease. Finally, vanishing bile duct syndrome is an example of chronic rejection in liver transplantation, where the intrahepatic bile ducts in the liver are progressively destroyed and eventually disappear. Unfortunately, chronic transplant rejection is a progressive process that up until now can't be prevented or treated. Okay, finally, there's graft versus host disease, or GVHD for short, which is similar to transplant rejection, but works the other way around. In other words, it's the graft that's rejecting the recipient or host. Graft versus host disease is a type 4 hypersensitivity reaction that's especially common with grafts that are rich in lymphocytes, such as the bone marrow or liver. What happens is that the T lymphocytes from an immunocompetent donor attack the cells of the immunocompromised host, causing severe organ dysfunction. Symptoms of graft versus host disease can include maculopapular rash with red and raised lesions, and most often involves the palms and soles. In addition, individuals may often develop hepatosplenomegaly, or enlarged liver and spleen, associated with jaundice or yellow skin. Graft versus host disease may also frequently cause diarrhea and abdominal pain. Less frequently, chronic graft versus host disease can affect the lungs, causing dyspnea or shortness of breath, as well as the muscles, causing muscle cramps and weakness. The good news is that graft versus host disease can be prevented by irradiating blood products to kill the lymphocytes prior to transfusion. In certain situations, though, graft versus host disease can be induced on purpose in individuals who have leukemia, where the donor T cells from a bone marrow transplant attack and kill the host's leukemic cells. This is called graft versus tumor effect. All right, as a quick recap, anaphylactic transfusion reaction is a type 1 hypersensitivity reaction mediated by the recipient's IgEs against the donor's plasma proteins. that starts within seconds to minutes from the transfusion and can manifest as urticaria, pruritus, wheezing, hypotension, and can evolve into respiratory arrest or shock. Acute hemolytic transfusion reaction is a type 2 hypersensitivity that occurs in cases of ABO incompatibility, leading to intravascular hemolysis within 24 hours due to preformed antibodies. On the other hand, delayed hemolytic transfusion reaction results from newly formed antibodies against minor antigens on red blood cells, like Rh, causing extravascular hemolysis after 24 hours. Febrile non-hemolytic transfusion reaction can result from the release of cytokines from white blood cells present in donor blood, causing fever, chills, headache, and flushing. Transfusion-related acute lung injury that results in fluid accumulation in the lungs within minutes to 6 hours, leading to non-cardiogenic pulmonary edema. On the other hand, transfusion-associated circulatory overload typically occurs due to fluid overload in individuals with congestive heart failure or chronic kidney disease, and presents within 6 hours of the transfusion with respiratory distress and cardiogenic pulmonary edema. Next, we have transplant rejection. Hyperacute transplant rejection is a type 2 hypersensitivity reaction that occurs within minutes of the transplant and results in a widespread thrombosis in the graft's vessels, leading to ischemia and necrosis of the transplanted organ. Acute transplant rejection is a mixed type 2 and 4 hypersensitivity reaction against the MHCs on graft cells that usually starts within weeks to months after the transplant. On histology of the graft, there's dense interstitial lymphocytic infiltrate and vasculitis. On the other hand, chronic transplant rejection starts months after the transplant and is mediated by type 2 and 4 hypersensitivity reactions, where antigen-presenting cells present graft antigens to the recipient's T cells. On histology, there's thickening of the graft's blood vessels, parenchymal atrophy, and interstitial fibrosis. Finally, graft versus host disease is a type 4 hypersensitivity reaction where the immune cells in the graft from an immunocompetent donor reject the cells of an immunocompromised host. This most often presents as a maculopapular rash, hepatosplenomegaly, jaundice, and diarrhea. Okay, back to our cases. Adam is a 35-year-old man who was involved in a motor vehicle crash and has significant bleeding from his thigh, and thus got a blood transfusion. Soon, he develops hypotension, which should make you think of anaphylactic transfusion reaction, acute hemolytic transfusion reaction, and transfusion-related acute lung injury. And the fact that he developed it just 5 minutes from starting the transfusion should help you rule out transfusion-related acute lung injury. Now, the final clue is that Adam's experiencing shortness of breath, vomiting, and urticaria. These clinical features are highly suggestive of an anaphylactic transfusion reaction. Jack is a 50-year-old man presenting with fever and malaise, as well as oliguria and hypertension. The biggest clue here is the fact that Jack had a kidney transplant, so you should immediately suspect some form of rejection. And because the transplant was done a month ago, it must be acute transplant rejection. This was confirmed with a kidney biopsy that revealed a dense lymphocytic infiltrate.
Immunodeficiencies can be classified into primary and secondary immunodeficiencies. Primary immunodeficiencies are relatively rare, genetic, and typically inherited defects in one or more of the elements of the immune system. Secondary immunodeficiencies are much more common, acquired disorders that occur as a result of some extrinsic factor affecting the immune system. Both primary and secondary immunodeficiencies can cause frequent or recurrent infections, specifically 6 or more new infections anywhere in the body within 1 year, or 4 or more new ear infections within 1 year. Sometimes, these infections turn out to be unusually severe. Specifically, it's unusual for 2 or more serious sinus infections or pneumonias to occur within 1 year, or 2 or more episodes of sepsis or meningitis to occur in a lifetime. Serious means that they cause persistent fever, or confinement to bed for a week or more, are difficult to treat requiring 2 or more months of antibiotics with little effect, or a need for IV antibiotics or hospitalization, or cause unusual complications. These include organ abscesses, non-healing wounds, chronic diarrhea, or failure to thrive, meaning failure to gain weight or grow normally, persistent laboratory abnormalities such as leukocytosis or elevated ESR and CRP, or persistent imaging abnormalities such as bronchiectasis. And then it's also concerning if the pathogens are opportunistic organisms such as Candida albicans, non-tuberculosis mycobacteria, or Pneumocystis jirovecii, which usually don't cause serious infections in individuals with a normal immune system. Okay, now secondary immunodeficiencies usually occur well after infancy, while most primary immunodeficiencies are inherited and present during the first few years. Secondary immunodeficiencies can be caused by underlying diseases like HIV infection, malnutrition, diabetes mellitus, malignancy, splenectomy, for example due to sickle cell disease, trauma or previous surgery, ionizing radiation, and immunosuppressive medications. Treatment is based on controlling the underlying disease or stopping the offending medication. On the other hand, primary immunodeficiencies can be classified according to the element of the immune system that is defective. The adaptive humoral defenses include immunoglobulins or antibodies produced by B lymphocytes that are CD19 positive and CD20 positive, while cellular defenses are mostly comprised of CD4 positive and CD8 positive lymphocytes. The innate cellular defenses are phagocytes, including neutrophils, and macrophages, while the innate humoral defenses are complement proteins. Antibody disorders are the most common type of primary immunodeficiencies. The main ones are selective IgA deficiency, X-linked agammaglobulinemia or Bruton's agammaglobulinemia, and hyper-IgM syndrome. Selective IgA deficiency is the most common and most benign immunodeficiency, characterized by low levels of IgA, resulting in low protection against infections of the mucous membranes lining the respiratory and gastrointestinal tracts, with normal production of IgM, IgG, IgD, and sometimes increased IgE. Most children with selective IgA deficiency have no symptoms, but sometimes there's a tendency to develop recurrent or persistent sinopulmonary or gastrointestinal infections. But there's also an increased frequency of atopy and asthma, as well as autoimmune diseases like rheumatoid arthritis. Finally, some individuals develop severe anaphylactic reactions when they're transfused with blood containing IgA, because the IgA is treated like a foreign antigen. Diagnosis is based on an IgA level below 7 mg per deciliter, with normal IgG and IgM in a child older than 4 years. A level above 7 mg per deciliter, but below what's expected for a given age, makes the diagnosis probable. Children should be monitored over time to see if IgA levels normalize. There's no effective treatment for selective IgA deficiency, but if a blood transfusion is needed, then washed erythrocytes should be used if possible. X-linked agammaglobulinemia is an X-linked recessive genetic condition, meaning that it almost exclusively manifests in males. There's a mutation that causes B cell maturation to stop, resulting in the absence of B cells and immunoglobulins. It typically appears after 6 months of age because that's when the maternal immunoglobulins from the placenta start to disappear. Usually, the child develops recurrent or severe bacterial infections like acute and chronic pharyngitis, sinusitis, otitis media, bronchitis, and pneumonia. These are typically caused by encapsulated organisms like Streptococcus pneumoniae and Haemophilus influenzae, and less commonly, enteroviral infections like Coxsackie virus, and finally, intestinal parasites like Giardia lamblia, all of which are usually neutralized by IgA in the respiratory and gut lining. In general, an IgG level lower than 200 mg per deciliter, a total immunoglobulin level of IgG plus IgM plus IgA lower than 400 mg per deciliter, or the complete absence of IgM or IgA after infancy are considered abnormal. Confirmation is done with flow cytometry showing markedly reduced CD19 positive and CD20 positive B cell levels. Additionally, we can measure IgG antibody titers to previously administered vaccine antigens to determine responsiveness to vaccination. These should be ideally checked 4 weeks after vaccination. Protein antigens such as tetanus, diphtheria, rubella, and mumps can be checked at all ages, while polysaccharide antigens such as Haemophilus influenzae and pneumococcus species can only be checked after 2 years of age. Treatment for X-linked A-gamma globulinemia includes lifelong monthly IVIG infusions with a dose depending on the child's weight and IgG blood count. This immunoglobulin is typically pooled across a lot of individuals and therefore provides a diverse set of antibodies which gives people with X-linked A-gamma globulinemia passive immunity and helps boost their immune system. Next is hyper-IgM syndrome. This is an X-linked recessive disorder caused by a defect in CD40 ligand or CD40L, which prevents class switching. This defect forces B cells to keep making IgM, which is the only form of antibody they produce before class switching. Symptoms present after 6 months of age and include predisposition to fungal infections like Pneumocystis jirovecii, which causes pneumonia, protozoa like Cryptosporidium, which causes chronic diarrhea and malabsorption, viruses like CMV, which causes pneumonia and hepatitis, and encapsulated bacteria like Streptococcus pneumoniae, causing otitis media, sinusitis, or pneumonia. Lab work shows an elevated IgM with reduced IgG, IgA, and IgE levels. This is confirmed by flow cytometry showing a deficient expression of CD40L on CD4 positive T lymphocytes. Treatment is of lifelong, monthly IVIG infusions with a dose depending on the child's weight and IgG blood count. Okay, next are T cell deficiencies. The main one is DiGeorge syndrome or 22q11.2 deletion syndrome. This is a genetic condition where the q11.2 portion of DNA on chromosome 22 is deleted, which can cause developmental midline defects. These include midline brain defects affecting the hypothalamus and pituitary gland, facial abnormalities such as cleft palate, a long face, small teeth, or broad nose, parathyroid gland hypoplasia causing hypocalcemia, hypoplasia or dysfunction of the thymus, congenital heart defects, in particular truncus arteriosus and tetralogy of Fallot, as well as mental health conditions like schizophrenia. Let's focus on thymic hypoplasia. T cells are produced in the bone marrow but mature in the thymus. If someone has thymic dysfunction, the T cells don't mature, and so these people often have a deficiency in mature T cells. It turns out, though, that most people with DiGeorge syndrome have mild to moderate thymic dysfunction called partial DiGeorge syndrome, which means that the immunodeficiency isn't life-threatening. Complete DiGeorge syndrome, though, where thymic dysfunction is severe, it can be fatal within the first year of life. Often, within 6 months of age, an infant begins having recurrent or severe infections from common viruses like varicella zoster virus, or opportunistic fungi like Candida albicans and Pneumocystis jirovecii, and bacteria like non-tuberculosis mycobacteria. Screening begins with a CBC with differential, a lymphocyte count below 1,500 cells per microliter in children over 5 years, or less than 2,500 cells per microliter in younger children is considered abnormal. After that, the next step is determining the function of T cells. This can be done both in vivo, meaning on the child, or in vitro, meaning in the lab. In vivo studies include delayed hypersensitivity skin tests to antigens like Candida, mumps, tetanus, or tuberculin that most people have been exposed to at one time in their lives. The process involves injecting a few antigen drops under the skin, usually on the forearm. The site is then observed for 72 hours for a raised red area signifying normally functioning T cells. In vitro studies measure the proliferation of peripheral blood T cells in response to certain stimuli, such as mitogens, like phytohemagglutinin, or PHA, and concanavalin A, or CON-A. The way this is done is that the child's purified peripheral blood lymphocytes are incubated in sterile media together with the mitogens for 3 to 6 days. A control tube with cells and media alone is also incubated. Radioactive thymidine is also added to the cultures so that the dividing lymphocytes incorporate the thymidine into their DNA. We can then quantify the extent of proliferation by measuring the radioactivity taken up by the cells. The test is then interpreted by comparing the proliferation of the lymphocytes in the test tube with normal control lymphocytes. If there's no response in either of these functional studies, we can then proceed to flow cytometry for lymphocyte subset analysis in order to determine the number and percentage of CD4 positive and CD8 positive T cells. Diagnosis is confirmed with fluorescence in situ hybridization, or FISH for short, which is a type of genetic testing able to detect the 22q11.2 deletion. A chest X-ray in some cases also reveals a hypoplastic thymus. No cure is available for DiGeorge syndrome, and a thymus transplantation might be required in children with complete DiGeorge syndrome. Now, it's also possible to have combined antibody and T cell deficiencies, and that's seen in severe combined immunodeficiency, ataxia telangiectasia, and Wiskott-Aldrich syndrome. Severe combined immunodeficiency, or SCID for short, is the most severe form of primary immunodeficiencies caused by a variety of gene mutations affecting the development of functional B and T cells. In fact, the immune system is so dysfunctional that it is considered almost completely absent. It usually presents in infancy as an extreme susceptibility to all kinds of infections, meaning bacterial, viral, and fungal infections, including opportunistic organisms like Pneumocystis jirovecii. There's often chronic diarrhea, as well as a failure to thrive. Diagnosis of SCID requires an absolute lymphocyte count lower than 2,500 cells per cubic millimeter, with T cells making up less than 20% of the total lymphocytes in flow cytometry, and a response to mitogens that's less than 10% of the control response. If left untreated, these infants have a high mortality rate in the first year. So hematopoietic stem cell transplantation is recommended before the age of 3 months. Until then, these infants are often kept in a sterile environment so that they are protected from pathogens. In addition, intravenous IgG infusions can be given about once a month, and antibiotic prophylaxis for Pneumocystis jirovecii infections can be given with trimethoprim sulfamethoxazole. Ataxia telangiectasia is an autosomal recessive disease caused by a mutation in the so-called ataxia telangiectasia mutated protein, or ATM protein, which normally fixes damaged DNA. This causes cells throughout the body to accumulate mutations and die. This results in ataxia, or poor coordination of movements, typically seen by age 2, telangiectasia, or small dilated blood vessels, visible especially on the white of the eyes by the age of 5 years, and telangiectasias that form on the skin by age 7. There is also an increased incidence of cancer, especially leukemia and lymphoma. About 2/3 also have low IgG, IgA, and IgE levels, along with low levels of T cells, causing recurrent infections, especially of the sinopulmonary tract. Diagnosis is made by detecting low levels of the ATM protein in cultured blood cells. Individuals are given prophylactic antibiotics and regular IVIG infusions. Wiskott-Aldrich syndrome is an X-linked recessive syndrome caused by a mutation in the so-called Wiskott-Aldrich syndrome protein, or WASP. Lack of this protein affects the cytoskeleton of hematopoietic cells. As a result, T cells and B cells aren't able to form an immunological synapse, resulting in an impaired immune response. For unclear reasons, this leads to an increase in IgA and IgE antibodies and normal or decreased levels of IgM and IgG antibodies. Regulatory T cells are also dysfunctional, making autoimmune diseases and cancers more likely. At the same time, megakaryocytes are less able to form platelets, and the platelets that are made are small and fragile, so it's called microthrombocytopenia and results in excessive bleeding. Additionally, there's eczema, also called atopic dermatitis, which is characterized by dry, red patches on the skin. So the classic triad of symptoms in Wiskott-Aldrich syndrome includes recurrent infections, easy bruising and bleeding, and eczema. The infections are classically due to encapsulated bacteria such as Streptococcus pneumoniae, Haemophilus influenzae, and Neisseria meningitidis, fungi such as Pneumocystis jirovecii and Candida albicans, and viruses such as Molluscum contagiosum, varicella zoster virus, and cytomegalovirus. Individuals are also more prone to developing autoimmune conditions such as idiopathic thrombocytopenic purpura and cancers like leukemia and lymphoma. The initial workup includes a peripheral smear, which would show thrombocytopenia with small platelets. Flow cytometry can be used to determine whether a mutated Wiskott-Aldrich syndrome protein is being produced, though it might not identify a severely mutated protein. The diagnosis is then confirmed by sequencing the Wiskott-Aldrich gene. Treatment includes prophylactic antibiotics, regular IVIG infusions, platelet transfusions in the case of severe bleeding, and potentially surgery to remove the spleen, which can help to maintain platelet counts within the blood. Hematopoietic stem cell transplantation is a potentially curative treatment that is sometimes used. Okay, next, there are also defects in phagocytes, mostly neutrophils. These mainly include leukocyte adhesion deficiency, chronic granulomatous disease, and Shediac-Higashi syndrome. Leukocyte adhesion deficiency is a genetic disorder inherited in an autosomal recessive pattern that occurs when neutrophils lack specific adhesion molecules such as CD18, a subunit of integrin molecules, or sialyl Lewis X, which enable them to pass through the endothelium of the blood vessel wall in order to reach the site of inflammation or tissue injury. It usually appears just after birth with recurrent or severe infections of the skin and soft tissue like cellulitis, or respiratory tract like pneumonia, as well as bone and joint infections like osteomyelitis and septic arthritis caused by bacteria like Staphylococcus aureus, Pseudomonas aeruginosa, Salmonella typhi, and Nocardia, and fungi like Candida and Aspergillus. Generally, resistance to viral infections remains intact. A unique thing about this type of infection is that there usually isn't pus or abscess formation. Leukocyte adhesion deficiency also causes a delay in umbilical cord sloughing, which typically lingers for a couple of months. Workup begins with the CBC with differential, which typically shows neutrophilia, or a neutrophil count 30,000 to 150,000 per cubic millimeters, since neutrophils stay trapped in the circulation. So the next step is flow cytometry in order to look for the expression of CD18 or silyl Lewis X on the leukocyte membrane. Supportive treatment involves prophylactic antibiotics and antifungals, usually trimethoprim sulfamethoxazole and itraconazole. However, the only curative treatment is a hematopoietic stem cell transplant. Chronic granulomatous disease is an autosomal recessive or X-linked recessive disease caused by a mutation in NADPH oxidase. As a result, phagocytes are unable to create superoxide, hydrogen peroxide, or hypochlorite ions, and so they struggle to kill catalase-positive pathogens. These can be remembered with the mnemonic "Cats have been places." Burkholderia, Nocardia, Pasteurella, Listeria, Aspergillus, Candida, E. coli, Staphylococcus, and Serratia. In terms of symptoms, chronic granulomatous disease usually presents before the age of 5 years with recurrent infections of the skin, soft tissue, respiratory tract, bone, and joints. The key here is that unlike leukocyte adhesion deficiency, pus and abscesses are present. On a CBC, the number of neutrophils is usually normal, and diagnosis proceeds by testing neutrophil function in a blood sample. A very old test is the nitroblue tetrazolium test, which is when a colorless dye called nitroblue tetrazolium is added to the blood sample. If the respiratory burst is working properly, superoxide ions are produced and react with the dye, changing its color to a deep blue. A newer test is the dihydrorhodamine 1,2,3 test, which is where dihydrorhodamine 1,2,3 is added to the blood sample. If levels of NADPH oxidase are normal, then the enzyme will oxidize dihydrorhodamine 1,2,3, causing it to fluoresce or shine. How much or how little it shines is directly proportional to the amount of functional NADPH oxidase. Supportive treatment of chronic granulomatous disease involves prophylactic antibiotics and antifungals, as well as interferon gamma, which can be given because it stimulates the production of superoxide in phagocytes. Once again, the only curative treatment is a hematopoietic stem cell transplantation. Last is Shediac-Higashi syndrome. This is an autosomal recessive disorder caused by a mutation in a lysosomal trafficking regulator protein. This impairs the ability of neutrophils to phagocytose and kill pathogens. It usually presents in infancy or early childhood with recurrent and severe bacterial and fungal infections and abscesses of the skin, soft tissue, respiratory tract, bone, and joints. For an unknown reason, there's also albinism, meaning abnormally light pigmentation of the skin, hair, and eyes, and peripheral neuropathy with loss of sensation in the arms and legs. On a CBC, the number of neutrophils is usually low, meaning less than 1,000 per microliter in infants and less than 1,500 per microliter in older children. Diagnosis is confirmed by bone marrow smears showing giant granules or inclusion bodies in leukocyte precursor cells. Treatment of Shediac-Higashi syndrome involves prophylactic antibiotics and antifungals until a hematopoietic stem cell transplantation is available. Alright, now finally, the rarest type of primary immunodeficiency is a deficiency in one or more complement proteins. Deficiencies in the classical pathway are usually inherited in an autosomal recessive pattern. Deficiencies in the early components of the classical complement pathway, meaning C1q, C1r, C1s, C4, or C2, are usually associated with autoimmune disorders, particularly systemic lupus erythematosus. Deficiencies in later components of the classical complement pathway cause recurrent infections. Specifically, deficiency of C3, which plays a central role in phagocytosis, often presents in the first few months or years with recurrent and severe infections with encapsulated organisms like Streptococcus pneumoniae and Haemophilus influenzae. Deficiencies in C5 through C8 impairing the formation of membrane attack complex, or MAC, usually cause symptoms in the late teenage years with recurrent Neisseria meningitidis infections such as meningitis, sepsis, and arthritis. Interestingly, individuals who are deficient in C9 seem to have no problems because C5, C6, C7, and C8 can lyse a bacterium all on their own, with C9 being the icing on the cake. Diagnosis of complement deficiencies of a component of the classical pathway starts by testing overall activity of the classical complement pathway, denoted by CH50 or CH100. If this is significantly reduced, or 0, then the levels of individual complement components are measured. Then, there are also deficiencies in the alternative pathway, the most common of which is properdin deficiency. This is X-linked and presents with a susceptibility to neisseриal infections, especially meningitis. The alternative pathway AH50 assay is used as a screen, followed by measurement of properdin levels. Finally, lectin pathway deficiencies mainly include deficiency of the mannose-binding lectin. This presents in neonates and early infancy with recurrent infections, especially with encapsulated bacteria. Diagnosis relies on low levels of mannose-binding lectin, or MBL, in the blood. Definitive treatment of complement deficiencies would require replacing the deficient protein through direct infusion of the protein. But since this is not available yet, treatment is only symptomatic and involves early recognition and treatment of infections, as well as vaccination, especially against Streptococcus pneumoniae or Haemophilus influenzae in children with C3 or mannose-binding lectin deficiency, and Neisseria meningitidis in those deficient in C5, C6, C7, C8, or properdin. Alright, as a quick recap, selective IgA deficiency is usually asymptomatic but may present with mucosal infections or anaphylactic reactions to blood transfusion. Diagnosis is made after the age of 4 years based on low plasma IgA levels. No treatment is available. X-linked A-gamma globulinemia presents after 6 months of age with severe infections mainly caused by encapsulated bacteria. The diagnosis is made based on low IgG, IgM, and IgA levels and is confirmed with flow cytometry showing low B-cell levels. Treatment is IVIG. Hyper-IgM syndrome also presents after 6 months of age with fungal, protozoal, viral, or encapsulated bacterial infections. Diagnosis is based on high IgM with low IgG, IgA, and IgE, and confirmed by flow cytometry showing an absent CD40L. Treatment is IVIG. The main T-cell deficiency is DeGeorge syndrome, which causes thymic hypoplasia and presents before 6 months of age with common viral infections or opportunistic fungal and bacterial infections. Diagnosis starts with a low total lymphocyte count, followed by functional T-cell tests, and is confirmed with genetic testing. Thymic transplantation is the treatment of choice. Severe combined immunodeficiency presents in infancy with various infections and is diagnosed based on low total lymphocyte count, low percentage of T cells in flow cytometry, and decreased response in functional T cell tests. A hematopoietic stem cell transplantation is necessary before 3 months of age. Ataxia telangiectasia presents with recurrent sinopulmonary tract infections, is diagnosed by low levels of the ATM protein, and treatment is supportive. And then, Wiskott-Aldrich syndrome has the triad of recurrent infections by encapsulated bacteria, microthrombocytopenia, and eczema. Diagnosis is made by flow cytometry and genetic tests. Treatment is supportive unless hematopoietic stem cell transplant is available. Leukocyte adhesion deficiency appears right after birth with recurrent bacterial and fungal infections with no pus, as well as delayed umbilical cord separation. CBC shows neutrophilia and diagnosis is confirmed with flow cytometry. Chronic granulomatous disease appears before age 5, with recurrent bacterial and fungal infections with pus. CBC shows a normal neutrophil count, and diagnosis is made with neutrophil function tests. And Shediac-Higashi syndrome appears in infancy or early childhood with recurrent bacterial and fungal infections with pus, along with albinism and peripheral neuropathy. CBC shows neutropenia, and diagnosis is confirmed with giant granules in cells of a bone marrow biopsy. In all neutrophil deficiencies, treatment is supportive or ideally hematopoietic stem cell transplantation. Finally, among complement deficiencies, there's C3 and mannose-binding lectin deficiency, causing susceptibility to pneumococcus and Haemophilus, and membrane attack complex and properdin deficiency, causing recurrent Neisseria meningitidis infections. In C3 and MAC deficiencies, diagnosis requires a CH50 test and low C3, or C5, C6, C7, and C8 levels respectively, whereas mannose-binding lectin deficiency needs a low MBL level, and properdin deficiency an AH50 test and low properdin levels. Treatment is supportive.
Gaia, a 6-year-old girl, is brought to the clinic by her parents because she's been having diarrhea and abdominal cramps for the past few weeks. When you ask about her clinical history, her parents tell you that Gaia was diagnosed with celiac disease a few years back. However, they point out that she stopped consuming any food products that may contain gluten altogether. You decide to first run stool tests, which reveal the presence of the parasite Giardia lamblia. In addition, Gaia's parents tell you that she has a history of asthma and allergic rhinitis, so you also order an immunoglobulin test which shows low IgA and increased IgE levels in her blood. Next comes Joe, a 10-year-old boy that's brought to the clinic because he fell and broke his arm. Upon physical examination, you notice a red, weeping rash on his scalp. You also notice that there's a skin abscess on his leg that lacks any surrounding warmth and redness. Joe's parents tell you that he develops abscesses like that all the time. You order an immunoglobulin test for Joe too, which reveals increased IgE but normal IgA levels. Based on the initial presentation, both cases seem to have some form of immunodeficiency, meaning that their immune system's ability to fight pathogens is compromised. Immunodeficiencies can be classified according to the cell of the immune system that is defective, into B cell and T cell disorders, which respectively lead to a deficiency in humoral or antibody-mediated and cell-mediated immune responses. Let's begin with B cell disorders, starting with Bruton or X-linked agammaglobulinemia, or XLA for short. This is caused by a mutation in the BTK gene, which is found on the X chromosome. XLA is an X-linked recessive condition, so it almost exclusively manifests in biological males because they have only one X chromosome. On the other hand, biological females have 2 X chromosomes, so even if they have a defective BTK gene on one chromosome, they still have another functional one. Now, the BTK gene codes for an enzyme called Bruton's tyrosine kinase, or BTK, which has an important role in the maturation process of the B cells at the bone marrow. Normally, once B cells are mature and ready, they can migrate from the bone marrow to the spleen, where they're exposed to antigens, and finally move into the blood or lymph and become an antibody-secreting plasma cell. With XLA, though, there's a mutation in the BTK gene that makes the BTK enzyme ineffective. As a result, the B cell maturation process stops at the bone marrow, so these B cells can't leave it to become plasma cells. Ultimately, people with XLA completely lack or have far fewer circulating B cells, so they also lack circulating antibodies of all classes. The end result is a deficiency of B cell and antibody-mediated immunity. Symptoms of XLA are typically absent until after 6 months of age, which is when they run out of the mother's supply of immunoglobulins that they received through the placenta during pregnancy. And that's a very high-yield concept to keep in mind. Now, after 6 months of age, children with XLA become very susceptible to recurrent infections. For your exams, remember that these infections are typically caused by encapsulated bacteria, so Streptococcus pneumoniae, Neisseria meningitidis, Klebsiella, Haemophilus influenzae, and Pseudomonas aeruginosa. Most often, these bacterial infections affect the respiratory tract, causing sinusitis, otitis media, pharyngitis, bronchitis, and pneumonia. Less commonly, children with XLA may also get viral infections, especially from enteroviruses like polio and Coxsackie virus, as well as protozoal infections from intestinal parasites like Giardia lamblia. Having said that, it's important to remember that T-cell-mediated immunity remains intact, and some viral, fungal, and protozoal infections can still be cleared. Another high-yield fact is that these individuals must avoid live attenuated vaccines like the live polio vaccine because the lack of antibodies makes even certain weakened pathogens tough to destroy. Diagnosis typically begins with a physical examination where lymph nodes and tonsils are diminished in size. For your exams, remember that this is known as lymphoid hypoplasia and is due to the lack of primary follicles and germinal centers, which are normally the B-cell compartments in healthy lymphoid tissues. The next step for diagnosis involves blood tests revealing the complete absence of B cells, as well as decreased levels of all immunoglobulin classes. Finally, diagnosis can be confirmed through genetic tests looking for the mutated BTK gene. Treatment for XLA includes lifelong intravenous infusion of immunoglobulins, and if there is a bacterial infection, these individuals should be started on antibiotics right away. Next up, selective IgA deficiency is the most common and least serious immunodeficiency. Though the exact mutation is unknown, the end result is a failure of IgA-producing B cells to mature into plasma cells. As a result, these individuals have low levels of IgA, which is normally the main antibody protecting the mucous membranes lining the respiratory and gastrointestinal tracts. However, what's important to keep in mind is that the production of other antibodies isn't affected. For that reason, most children with selective IgA deficiency have no symptoms, but some of them may have an increased tendency to develop recurrent infections involving the respiratory or gastrointestinal tracts. A high-yield gastrointestinal pathogen is the parasite Giardia lamblia, which is responsible for a diarrheal condition known as giardiasis. In addition, there's an increased frequency of atopy, mainly manifesting as asthma, rhinitis, and dermatitis, as well as autoimmune diseases like rheumatoid arthritis and celiac disease, although the link between them is not fully understood. Finally, some individuals develop severe anaphylactic reactions when they're transfused with blood containing IgA because the IgA is recognized like a foreign antigen and attacked by the immune system. Diagnosis is based on blood tests showing low IgA levels, normal levels of IgM and IgG, and sometimes increased IgE. There's no specific treatment for selective IgA deficiency. The last B-cell disorder you should know for your exams is common variable immunodeficiency, or CVID for short. Now, the exact mutation that causes CVID remains largely unknown, but it is thought to result from a combination of several mutations that ultimately make mature B cells unable to differentiate into antibody-producing plasma cells. For your exams, it's important not to confuse this with X-linked A-gamma globulinemia, where there's an absence of mature B cells altogether. As the name suggests, symptoms tend to vary a lot. Most often, they first appear during puberty or early adulthood and include recurrent infections, mainly of the respiratory tract. Over time, if these infections are not properly treated, they can lead to the development of bronchiectasis, meaning their bronchi become abnormally enlarged. And that's a high-yield fact. In addition, for unknown reasons, individuals with CVID are at an increased risk of developing malignancies, especially lymphomas, as well as autoimmune conditions like autoimmune anemia, thrombocytopenia, or arthritis. For diagnosis, what you must know is that laboratory tests demonstrate an overall decrease in plasma cells and immunoglobulins. Also, it's important to note that genetic testing can't confirm the diagnosis of CVID, but it can be useful to rule out similar conditions, such as X-linked A-gamma globulinemia. Treatment for CVID includes lifelong intravenous infusion of immunoglobulins. In addition, individuals with autoimmune conditions may require immunosuppressive treatment with corticosteroids, while recurrent bacterial infections can be treated with antibiotics. Okay, next are T-cell disorders. Let's start from a very high-yield disease, which is 22q11.2 deletion syndrome, also called thymic aplasia. If these names don't ring a bell, you probably know it as DeGeorge syndrome, which is in fact one presentation of 22q11.2 deletion syndrome, along with velocardiofacial syndrome. Now, 22q11.2 deletion syndrome is an autosomal dominant condition where the q11.2 portion of DNA on chromosome 22 is deleted, and this region encodes for some really important genes, one of which is the TBX1 gene. Now, TBX1 gene is involved in normal embryonic development of the pharyngeal pouches, which are fetal structures that develop into parts of the head and neck. More specifically, for your exams, you should know that the ones affected are the third pharyngeal pouch, which goes on to develop into the thymus and the inferior parathyroid glands, as well as the fourth pouch, which goes on to develop into the superior parathyroid glands. So, with a 22q11.2 deletion, and therefore no TBX1 gene, the thymus and parathyroid gland both end up hypoplastic, meaning that they are underdeveloped. And that's a high-yield fact. Now, parathyroid gland hypoplasia leads to low levels of parathyroid hormone, which causes hypocalcemia or low levels of calcium in the blood, and this can manifest as osteoporosis and tetany, or involuntary contraction of muscles. On the other hand, thymic hypoplasia results in a T-cell disorder since the thymus is where T-cells mature. As a result, these individuals are more susceptible to recurrent infections. Often within 6 months of age, infants begin having recurrent or severe infections from common viruses like varicella zoster virus, or opportunistic fungi like Candida albicans and Pneumocystis jirovecii, and bacteria like non-tuberculous mycobacteria. Now, in addition to affecting the thymus and parathyroid glands, you must know that deletion of the 22q11.2 region can also affect various other organs and tissues. This includes the heart, resulting in congenital heart defects, in particular truncus arteriosus and tetralogy of Fallot, as well as the facial structures, resulting in abnormal facies, such as cleft palate, a long face, small teeth, or broad nose. Finally, some individuals may also have speech or learning disabilities. As we said earlier, you must absolutely know that there are two main presentations of 22q11.2 deletion syndrome: DeGeorge and velocardiofacial syndromes. These have overlapping features, however, DeGeorge syndrome mainly presents with thymic, parathyroid, and cardiac defects, whereas velocardiofacial syndrome is mostly characterized by facial and, again, cardiac defects. And these are very high yield, especially DeGeorge syndrome. Diagnosis begins with blood tests revealing decreased T-cell levels, low parathyroid hormone, and hypocalcemia. It's also important to know that a chest X-ray, in some cases, can reveal the absence of the thymic shadow, which indicates thymic hypoplasia. Finally, diagnosis can be confirmed with fluorescence in situ hybridization, or FISH for short, which is a type of genetic testing able to detect the 22q11.2 deletion. There is no cure available for 22q11.2 deletion syndrome. Infections can be treated with antibiotics, and hypocalcemia can be managed with vitamin D and calcium supplements. Severe cases may require surgery, like a thymus transplant for those with thymic hypoplasia, or heart surgery for children with congenital heart defects. Another T-cell disorder is IL-12 receptor deficiency. This is an autosomal recessive disease caused by mutations in the IL-12RB1 gene that codes for the interleukin or IL-12 receptor, which is normally involved in the activation of cell-mediated immunity against intracellular pathogens. Long story short, here's what you need to know. When an antigen-presenting cell comes in contact with an antigen, it produces IL-12, which interacts with IL-12 receptors found on the surface of T helper cells. This makes the T helper cells differentiate into Th1 cells, which in turn produce interferon gamma to activate macrophages and cytotoxic T cells. In addition, IL-12 activates natural killer or NK cells. And together, macrophages, cytotoxic T cells, and NK cells are the main players in cell-mediated immunity. Now, individuals with IL-12 receptor deficiency lack this cell-mediated immunity, which makes them more susceptible to develop disseminated infections from intracellular pathogens, meaning pathogens that are able to invade our cells and live inside them. Intracellular pathogens include bacteria, such as Salmonella or mycobacteria like tuberculosis, as well as some fungi like Candida. You should also know that these individuals may even develop an infection from getting the Bacillus Calmette-Guerin or BCG vaccine, as it contains live attenuated mycobacteria that these individuals can't fight. These findings are collectively called Mendelian susceptibility to mycobacterial disease, or MSMD for short. Diagnosis of IL-12 receptor deficiency involves laboratory tests showing decreased levels of interferon gamma and can be confirmed with genetic testing. The only cure is hematopoietic stem cell transplantation. Up next, we have autosomal dominant hyperimmunoglobulin E or hyper-IgE syndrome, also known as Job syndrome. This is an autosomal dominant disease due to a mutation in the STAT3 gene, which codes for the transcription factor STAT3. Normally, STAT3 is a key factor in the differentiation of T helper cells into Th17 cells, which produce interleukin or IL-17 to recruit neutrophils to the infection site. Once there, neutrophils trigger an acute inflammatory response to get rid of the infectious pathogen. Now, in hyper-IgE syndrome, the mutated STAT3 affects the differentiation of Th17 cells. As a consequence, neutrophil recruitment is impaired, thus infections occur without an acute inflammatory response. The most common symptoms of hyper-IgE syndrome include eczematous skin rashes, meaning they're red, weeping, and itchy, which most often involve the scalp and face, as well as bacterial lung infections, and recurrent cold or non-inflamed staphylococcal skin abscesses, which lack the typical signs of acute inflammation like warmth, redness, and tenderness. In addition, many individuals have characteristic coarse facies, which can include a prominent forehead, flat nose, and large tongue, and they may also fail to lose and replace their primary or baby teeth with permanent teeth. Finally, these individuals may also have osteopenia or decreased bone mineral density, and what's important is that this makes them more prone to frequent fractures, even from minor trauma. Now, diagnosis is based on blood tests. For unknown reasons, these individuals have abnormally increased levels of IgEs, which is where hyper-IgE syndrome gets its name from. Another high-yield finding is eosinophilia, or increased eosinophils. There's no cure for hyper-IgE syndrome, but many individuals with hyper-IgE syndrome are treated with long-term antibiotics to help prevent infections. The final T-cell disorder is chronic mucocutaneous candidiasis, which refers to a group of disorders that are characterized by chronic fungal infections caused by the Candida species. Most cases of chronic mucocutaneous candidiasis are caused by an autosomal recessive mutation in the AIRE gene, which codes for a protein called autoimmune regulator, or AIRE for short. Normally, AIRE is involved in the T-cell selection process that takes place in the thymus, where self-reactive T-cells are eliminated to prevent them from going around and attacking other cells throughout the body. Now, with chronic mucocutaneous candidiasis, deficiency in AIRE ultimately results in T-cell dysfunction and impaired cell-mediated immunity. As a result, these individuals have a tendency to develop recurrent, non-invasive Candida infections involving the skin, nails, and mucous membranes. In addition, they can develop autoimmune manifestations that most often affect the thyroid, parathyroid, and adrenal glands, but can also lead to anemia, thrombocytopenia, neutropenia, and arthritis. Diagnosis of chronic mucocutaneous candidiasis involves assessing their response to candida antigens by doing in vitro T-cell proliferation assays and in vivo cutaneous reaction testing. In chronic mucocutaneous candidiasis, both in vivo and in vitro tests fail to elicit a response to candida antigens. Diagnosis can be confirmed via genetic testing, which reveals a mutation in the AIRE gene. Once again, no cure is available, so treatment involves antifungals and managing the associated autoimmune manifestations. Alright, as a quick recap, B-cell disorders include X-linked A-gamma globulinemia, selective IgA deficiency, and common variable immunodeficiency. X-linked A-gamma globulinemia is caused by an X-linked recessive mutation in the BTK gene, which results in the absence of circulating mature B cells and immunoglobulins, leading to recurrent bacterial and enteroviral infections after 6 months of age and lymphoid hypoplasia. Selective IgA deficiency is characterized by low levels of IgA and is usually asymptomatic but may present with mucosal infections, autoimmune diseases, atopy, and anaphylactic reactions to IgA-containing blood products. Common variable immunodeficiency is characterized by failure of mature B cells to differentiate into plasma cells, leading to recurrent infections, bronchiectasis, malignancies like lymphomas, or autoimmune manifestations. Next, T-cell disorders include 22q11.2 deletion syndrome, IL-12 receptor deficiency, autosomal dominant hyper-IgE syndrome, and chronic mucocutaneous candidiasis. 22q11.2 deletion can present as DeGeorge syndrome with thymic, parathyroid, and cardiac defects, or velocardiofacial syndrome with mainly facial and cardiac defects. IL-12 receptor deficiency is an autosomal recessive disease that impairs the immune response to intracellular pathogens, which causes Mendelian susceptibility to mycobacterial disease. Autosomal dominant hyper-IgE syndrome, or Job syndrome, is due to a mutated STAT3, which impairs neutrophil recruitment and mainly presents as eczematous skin rashes, bacterial lung infections, and recurrent cold staphylococcal skin abscesses. Individuals have characteristic coarse facies, fail to lose their primary teeth, and are more prone to bone fractures due to osteopenia. Finally, chronic mucocutaneous candidiasis is most often caused by an autosomal recessive mutation of AIRE, leading to recurrent non-invasive candida infections involving the skin and mucous membranes, as well as autoimmune manifestations. Okay, back to our cases. Gaia is a 6-year-old girl that has gastrointestinal issues, and her stool tests reveal that she had giardiasis. This is a very frequent infection among those with B-cell deficiencies. Gaia also suffers from celiac disease, asthma, and allergic rhinitis, which combined should make you think of selective IgA deficiency. The final clue is her immunoglobulin test, which shows low IgA and increased IgE levels. Joe is a 10-year-old boy that presents with a fractured arm. His immunoglobulin test also reveals increased IgE levels, but IgA levels are normal. The high IgEs are probably associated with the eczematous skin rash on his scalp. Now, if you combine these findings with the history of recurrent cold abscesses, diagnosis of hyper-IgE syndrome is highly likely. This was confirmed with genetic testing that revealed a mutated STAT3 gene.
Alyssa is a 3-week-old newborn baby girl that's brought to the clinic by her parents. They're a bit concerned because they've noticed that Alyssa's umbilical cord stump hasn't fallen off yet. On physical examination, you notice that the stump looks red and swollen, but there's no pus. You decide to run a blood test, which reveals an increased level of neutrophils. Finally, you perform flow cytometry, which shows that these neutrophils have reduced expression of CD18. Next comes Eddie, a 2-year-old boy who has a fever that won't go away after 2 weeks. His parents also mention that he has frequent infections involving the respiratory tract, and he once also had an infection of the knee joint. Upon physical examination, the first thing you notice is that Eddie has extremely light skin, hair, and eyes. Then you find swollen lymph nodes all around the body, and you palpate an enlarged liver and spleen. So again, you run some blood tests, but now you find decreased white blood cells, especially neutrophils, and a prolonged bleeding time. Finally, you do a peripheral and bone marrow smear, which shows abnormally large granules within the white blood cells and platelets. Based on the initial presentation, both cases seem to have some form of immunodeficiency, meaning that their immune system's ability to fight pathogens is compromised. Immunodeficiencies can be classified according to the component of the immune system that is defective. In this video, we'll be focusing on phagocyte dysfunction and complement disorders. Okay, let's start with phagocyte dysfunction. First, we have leukocyte adhesion deficiency, which is an autosomal recessive disorder, meaning that an individual needs to inherit 2 copies of the mutated gene, one from each parent, to develop the condition. Normally, when there's an infection or inflammatory process, as well as for wound healing, chemical signals are released by cells in the affected area to attract leukocytes, such as phagocytes, that are circulating in the blood, and this is called chemotaxis. But to actually get to the affected area, they first have to squeeze and pass through the endothelial cells that line the blood vessel wall. To do this, what's important to know is that there's a tight interaction between cellular adhesion molecules on the surface of endothelial cells and the integrins on the surface of the phagocytes. Once at the infected site, phagocytes start phagocytosing, or eating invading pathogens and damaged cells, and then undergo apoptosis, or programmed cell death, destroying themselves and all of the pathogens they've taken in. This may form a collection of pus, which can accumulate in closed tissue spaces and develop into an abscess. Now, there are many types of leukocyte adhesion deficiency, but the most common and high-yield one is type 1. So, type 1 leukocyte adhesion deficiency is caused by a mutation in the gene coding for CD18, which is a subunit of integrin molecules. Without integrins, phagocytes in the circulation can't make their way to the infected or damaged tissues. This allows pathogens like bacteria and fungi to spread uncontrollably, causing recurrent bacterial or fungal infections of the skin or mucosal membranes. A high-yield fact is that there's never pus or abscess formation since the neutrophils never make it to the pathogens. Another important thing to keep in mind for your exams is that these patients are also at risk for much more serious infections, such as pneumonia or peritonitis. Unfortunately, because of this, life expectancy can be severely shortened, and many babies don't survive past infancy. At the same time, without the help of phagocytes, damaged cells and tissue debris cannot be removed. As a consequence, wounds are slow to heal, leading to poorly formed, thin, and bluish scars. Now, a very high-yield fact is that phagocytes are also required to help the umbilical cord stump separate or fall off from the baby's belly button. For your exams, remember that this normally takes 1 to 2 weeks, while with leukocyte adhesion deficiency, it may take longer than a month, and it can often get inflamed and infected, but again, there's no pus. Diagnosis is based on the elevated number of phagocytes, especially neutrophils, in the blood. This is because they simply don't move into pathogen-infected tissue. For this reason, they're also absent at the infection sites. Diagnosis can be confirmed with flow cytometry, looking for reduced expression of CD18 on the membrane of phagocytes. For treatment, prophylactic antibiotics are often given to help prevent serious infections, while the only cure is a hematopoietic stem cell transplant that can replace all types of blood cells, including new leukocytes that are able to extravasate normally. Another high-yield phagocyte dysfunction is Shigyaki-Gashi syndrome, which is also autosomal recessive. The mutated gene here is the LIST gene, which codes for the lysosomal trafficking regulator, or LIST for short. LIST is a vesicular transport protein that's particularly important for the transport of substances into lysosomes. Normally, when a phagocyte detects a pathogen, it wraps around it and engulfs it, forming a vesicle inside the phagocyte called a phagosome. Then the phagosome fuses with a lysosome, forming a phagolysosome, and lysosomal enzymes destroy the pathogen. In Shigyaki-Gashi syndrome, there's defective transport into lysosomes, which results in an impaired phagolysosome formation. Affected phagocytes produce giant granules but are unable to kill engulfed pathogens. Platelets are also affected in Shigyaki-Gashi syndrome. That's because, normally, platelets have intracellular vesicles or granules that contain clotting and platelet activating factors. But in Shigyaki-Gashi syndrome, these granules can't be released, so they become giant and there's impaired platelet aggregation. Another type of cells affected in Shigyaki-Gashi syndrome are melanocytes, which produce a protein pigment called melanin. Melanin is stored in vesicles called melanosomes, which then carry it to the surrounding tissue cells, and it contributes to the color of our skin, hair, and eyes. In Shigyaki-Gashi syndrome, melanosomes fail to transport melanin to the surrounding cells. Finally, neurons also rely on vesicular transport to release neurotransmitters and communicate with other cells. As a consequence, Shigyaki-Gashi syndrome can cause damage to neurons. Because of all this, Shigyaki-Gashi syndrome usually presents in infancy or early childhood, with a classic combination of recurrent infections and abscesses, mild coagulation defects, albinism, and neurologic symptoms, including progressive neurodegeneration and peripheral neuropathy, with loss of sensation in the arms and legs. For your exams, remember that infections are typically severe, are caused by bacteria or fungi, and can involve skin, soft tissues, respiratory tract, bones, and joints. Ultimately, many individuals with Shigyaki-Gashi syndrome reach the so-called accelerated phase, in which lymphocytes start proliferating uncontrollably and can invade and damage various organs, including the liver, spleen, and the bone marrow. This is known as lymphohistiocytosis and can manifest with fever, lymphadenopathy or swollen lymph nodes, hepatosplenomegaly or enlarged liver and spleen, and pancytopenia or low counts of red blood cells, white blood cells, and platelets. Diagnosis of Shigyaki-Gashi syndrome begins with blood tests, which show pancytopenia or a decrease in all types of blood cells, especially neutrophils, and a prolonged bleeding time. Confirmation comes with a peripheral and bone marrow smear showing giant clumped up granules within granulocytes and platelets. Finally, genetic tests can also be done to look for mutations in the LIST gene. For treatment, antibiotics can be used to treat infections, and individuals in the accelerated phase may get chemotherapy, but the only cure for Shigyaki-Gashi syndrome is a bone marrow transplant. The last high-yield phagocyte dysfunction is chronic granulomatous disease, which is caused by mutation in the genes that code for the enzyme complex NADPH oxidase. There are many ways to inherit these mutations, but the most important for your exams is an X-linked recessive mutation, and since men only have one X chromosome, they get the disease, whereas because women have two X chromosomes, they only get the disease if both of their X chromosomes are affected. Remember the phagolysosome? Great! So if we zoom into its membrane, we'll find this enzyme complex called NADPH oxidase. And inside the phagolysosome, we have the lysosomal enzymes that can destroy a pathogen. The lysosomal enzymes also activate NADPH oxidase, which causes NADPH to undergo oxidation and lose 2 electrons. Nearby oxygen molecules can grab these electrons to form superoxide ions, or O2- ions. Another enzyme called superoxide dismutase can then take these superoxide ions and combine them with the hydrogen ions, forming hydrogen peroxide, or H2O2. Finally, superoxide ions and hydrogen peroxide destroy pathogens by breaking down their cell membranes and damaging their proteins. This process is called the respiratory burst, and it's very high yield. Now, in chronic granulomatous disease, there's a decrease in the amount of functioning NADPH oxidase, so there's less superoxide ions and hydrogen peroxide, resulting in a weaker respiratory burst. This makes it difficult to kill certain pathogens, specifically fungi and bacteria that have an enzyme called catalase, and are therefore called catalase-positive pathogens. To help you remember these pathogens, remember the mnemonic "Cats have been places," which stands for Burkholderia, Nocardia, Pastorella, Listeria, Aspergillus, Candida, E. coli, Staphylococcus, and Serratia. Now, what catalase does is break down hydrogen peroxide into water and oxygen, rendering it harmless. Normally, there's enough hydrogen peroxide being produced, so catalase-positive pathogens can only break down some of it. But in the case of chronic granulomatous disease, there's already so little hydrogen peroxide that catalase-positive pathogens can break down all of it. Over time, phagocytes gather up to stop the pathogen from spreading, forming little clusters called granulomas throughout the body. So they're not killing the pathogens, but at least they're keeping them sort of under control. And that's where chronic granulomatous disease gets its name from. In terms of symptoms, individuals can develop recurrent pneumonia or recurrent skin and soft tissue infections like cellulitis and abscesses, as well as bone and joint infections like osteomyelitis and septic arthritis. It's also common to see bacteremia or fungemia, which is when the pathogens that don't get killed find their way into the bloodstream. Diagnosis of chronic granulomatous disease involves testing neutrophil function in a blood sample. A very old test is the nitroblue tetrazolium test, which is when a colorless dye called nitroblue tetrazolium is added to the blood sample. If the respiratory burst is working properly, superoxide ions are produced and react with the dye, changing its color to a deep blue, while in chronic granulomatous disease, the sample fails to turn blue. A newer test is the dihydrorhodamine 123 test, which is where dihydrorhodamine 123 is added to the blood sample. If levels of NADPH oxidase are normal, then it will oxidize dihydrorhodamine 123, causing it to shine with a green color or fluorescence. But in chronic granulomatous disease, there's reduced green fluorescence. Treatment of chronic granulomatous disease involves prophylactic antibiotics and antifungals. In addition, interferon gamma can be given to stimulate the production of superoxide in phagocytes. In some cases, a hematopoietic stem cell transplantation can be done. Okay, now, we've reached our final topic, which is complement deficiencies. Here, there's a deficiency in one or more of the complement proteins. Let's start with the complement proteins that make up the complement system, going from C1 all the way to C9. Generally speaking, each complement protein is normally inactive, and it becomes activated when it's cleaved, meaning that a part or fragment of it is removed. Normally, the complement system helps with the immune response through three mechanisms. First, it enhances the function of phagocytes by opsonization, meaning that complement proteins bind to and coat the pathogens or damaged cells' membranes, as well as immune complexes made up of antibodies bound to pathogenic antigens, so that they can be more easily picked up by the phagocytes. The main opsonin complement protein is C3b. This is an active fragment of C3, and its cleavage involves complement proteins C1, 2, and 4. And so C1 to 4 are called the early components of the complement system. Second, the complement promotes inflammation and chemotaxis by recruiting immune cells into the affected area, which is mainly carried out by C3a. That's a fragment of C3, as well as C5a, which is a fragment of C5. And third, proteins C5b and C6 to C9 cluster in the pathogen's membrane and form the membrane attack complex, or MAC, which creates a hole in the membrane and ultimately kills the pathogen. And so, C5 to C9 are called the terminal components of the complement system. For your tests, keep in mind that the formation of the MAC complex is especially useful against Neisseria meningitidis and gonorrhoeae. Now, many cases of complement deficiency are inherited, and most are autosomal recessive. However, remember that it's also possible to develop an acquired complement deficiency. For example, when a severe infection or autoimmune condition causes complement proteins to get used up. For your exams, a high-yield example is systemic lupus erythematosus, which causes both C3 and C4 protein deficiency. So, complement deficiencies can be classified as early complement deficiencies when they involve C1 to C4, and terminal complement deficiencies when they involve C5 to C9. Early complement deficiencies are associated with an increased risk of severe recurrent pyogenic infections, mainly involving the sinuses and respiratory tract. In addition, due to the decreased clearance of damaged cells and immune complexes, these individuals often develop autoimmune manifestations, the most high-yield one being, again, systemic lupus erythematosus. On the other hand, terminal complement deficiencies impair the formation of the MAC and bear in mind that individuals are particularly susceptible to recurrent Neisseria infections, so they're at higher risk for developing meningitis or gonorrhea. Diagnosis of complement deficiencies can be done through blood analysis by testing overall complement activity denoted by CH50 or CH100. In addition, it's possible to test for specific protein levels like C3 or C4. Treatment of complement deficiencies depends on the cases. It's important to treat harmful infections and to take precautions like prophylactic antibiotics. In addition, individuals that develop autoimmune manifestations can be given immunosuppressors. Alright, as a quick recap, leukocyte adhesion deficiency type 1 is caused by an autosomal recessive mutation in the CD18 subunit of the LFA1 integrin, which is necessary for extravasation of phagocytes. This results in recurrent bacterial and fungal infections of the skin and mucosal membranes, impaired wound healing, and delayed separation of the umbilical cord. Shediaki-Gashi syndrome is an autosomal recessive disease caused by a mutated List gene, which impairs vesicular transportation, particularly to lysosomes, and is characterized by recurrent bacterial infections as well as defects in blood clotting, pigmentation, and neurologic function. Chronic granulomatous disease is caused by an X-linked recessive mutation in NADPH oxidase, resulting in an inability of phagocytes to create superoxide and hydrogen peroxide. This causes them to struggle to kill catalase-positive pathogens, which can be remembered with the mnemonic "cats have been places." Complement deficiencies are a group of disorders all of which have a deficiency in one or more complement proteins and can be inherited or acquired. Early complement deficiencies involve C1 to C4 and are associated with an increased risk of severe, recurrent, pyogenic infections of the sinuses and respiratory tract, as well as autoimmune manifestations like systemic lupus erythematosus. On the other hand, terminal complement deficiencies involve C5 to C9, and individuals are particularly susceptible to recurrent Neisseria infections. Okay, back to our cases. Alyssa is a 3-week-old newborn girl that's taken to the clinic because her umbilical cord stump still hasn't separated from her belly button. This already should make you think of leukocyte adhesion deficiency. Another very important fact here is that her stump is inflamed, but there's no pus, which would indicate that there are no neutrophils fighting the infection. However, her blood tests show high levels of neutrophils, which means they are somehow defective. The final clue is given by flow cytometry, which reveals that these neutrophils lack expression of CD18 on their membranes, which confirms the diagnosis of leukocyte adhesion deficiency type 1. Next comes Eddie, a 2-year-old albino boy who has frequent infections involving a variety of organs and tissues. He presents with a history of fever, lymphadenopathy, and hepatosplenomegaly. This may suggest lymphohistiocytosis, which is typical of the accelerated phase of Shediaki-Gashi syndrome. This is further supported by Eddie's blood tests, which show a combination of pancytopenia and a prolonged bleeding time. Finally, a peripheral and bone marrow smear reveals giant clumped up granules within granulocytes and platelets, which definitely confirms the diagnosis of Shediaki-Gashi syndrome.
Aurora, an 18-month-old girl, is brought to the clinic because of frequent respiratory and ear infections. At first glance, you notice she has some small dilated blood vessels over the sclera of her eyes. Upon physical examination, you also realize that she has a delay in speech, as well as frequent stumbling when walking. Laboratory studies are obtained, showing a low lymphocyte count, low immunoglobulin levels, and high alpha-fetoprotein, or AFP. Next comes Matthew, a 16-month-old boy that's brought to the clinic because of a skin rash that appeared on his back in infancy and won't go away. Matthew's mother tells you that he has frequent spontaneous nosebleeds and has had recurrent respiratory tract infections over the last few months. Laboratory studies are obtained, revealing that Matthew's platelets are quite small in size and fewer than normal, while the immunoglobulins IgA and IgE are increased. Based on the initial presentation, both cases seem to have some form of combined B and T cell disorder causing immunodeficiency, meaning that their immune system's ability to fight pathogens is compromised. Combined B and T cell disorders are characterized by deficits in the development of both B and T cells, which respectively lead to impaired antibody and cellular immune responses. For your exams, the most high-yield combined B and T cell disorders include severe combined immunodeficiency, ataxia-telangiectasia, hyper-IgM syndrome, and Wiskott-Aldrich syndrome. All right, let's get into it, starting with severe combined immunodeficiency, or SCID for short, which is the most severe form of primary immunodeficiency. In fact, the immune system is so dysfunctional that it's considered almost completely absent. Now, for your exams, remember that SCID can be caused by mutations in a variety of genes. The most common one codes for the gamma chain of the IL-2 receptor. For your exams, remember that this mutation is X-linked recessive. Okay, now this protein is a necessary component of the IL-2 receptor, which is involved in lymphocyte maturation and activation. In SCID, the mutated gamma chain leads to the production of a defective IL-2 receptor, and thus a lack of functional mature lymphocytes. Another high-yield form of SCID is ADA deficiency, or ADA-SCID, which is caused by an autosomal recessive mutation in the gene coding for adenosine deaminase, or ADA. Now, normally in the purine salvage pathway, ADA is required to degrade adenosine and deoxyadenosine. As a consequence, there's accumulation of adenosine and deoxyadenosine, and these can be toxic to B and T lymphocytes. In addition, the excess deoxyadenosine gets converted into deoxyadenosine triphosphate, or DATP. Accumulation of DATP leads to inhibition of the enzyme ribonucleotide reductase, which mediates the conversion of ribonucleotides to deoxynucleotides. The end result is an impaired DNA synthesis in B and T cells, which leads to failure in their maturation and proliferation. A third type of SCID to keep in mind is caused by an autosomal recessive mutation in the recombination activating genes, or RAG for short. These enzymes are necessary for a process called VDJ recombination, where multiple V, D, and J gene segments in the DNA of T and B cells are randomly recombined to create variability in the T and B cell receptors. So, mutation of the RAG genes prevent VDJ recombination, which means the B and T cell receptors lose their ability to recognize a wide variety of antigens. Now, regardless of the type of mutation, all forms of SCID typically present in infancy as an extreme susceptibility to all kinds of bacterial, viral, and fungal infections. Most importantly, these include opportunistic pathogens, such as Candida albicans, nontuberculosis mycobacteria, or Pneumocystis jirovecii, which don't usually cause serious infections in individuals with a healthy immune system. For your exams, remember that oral candidiasis presents with a characteristic oral thrush that's often described as cottage cheese-like thrush, but it isn't painful and can be scraped away with a tongue depressor, leaving behind a red mucosal base which sometimes bleeds. In addition, individuals often present with chronic diarrhea and a failure to thrive. If left untreated, SCID has a high mortality rate in the first year of life. Diagnosis of SCID in many countries is based on newborn screening tests. These measure T-cell receptor excision circles, or TREX, in blood. The presence of TREX is a biomarker for normal T-cell development, so remember that in SCID, TREX are absent. Laboratory tests are also required, showing an absolute lymphocyte count lower than 2,500 cells per cubic millimeter, with T cells making up less than 20% of the total lymphocytes in flow cytometry. Additional findings can include absence of thymic shadow on chest X-rays, as T-cell maturation normally takes place in the thymus. A lymph node biopsy shows absence of germinal centers, which is where mature B cells would normally proliferate to fight infections. Finally, to identify the specific form of SCID, genetic testing can be performed to look for the mutated gene. For treatment, hematopoietic stem cell transplantation is recommended before 3 months of age. Until then, these infants are often kept in a sterile environment to prevent infections. In addition, intravenous IgG infusions can be given about once a month to help boost their immune system. Next up, there's ataxia telangiectasia, where ataxia refers to poor coordination and telangiectasia refers to dilated blood vessels. And these are the 2 key symptoms of this disease. Ataxia telangiectasia develops due to a genetic mutation in the ATM gene, which codes for a protein called ataxia telangiectasia mutated kinase, or ATM kinase for short. Normally, the DNA of the cells in the body gets damaged throughout their lifespan. This can happen upon cell division, as well as from various environmental factors like ionizing radiation. When there's some kind of DNA damage, ATM kinase activates other proteins, which will either fix the DNA or kill the affected cell. Now, for your exams, keep in mind that ATM is particularly important for the development of B and T lymphocytes, since these cells are constantly dividing and rearranging their DNA to recognize a wide variety of antigens. So, this means they're much more prone to DNA damage as a result. In ataxia telangiectasia, cells don't have sufficient ATM to properly repair the damaged DNA. As a result, some of the defective cells might continue to grow and proliferate despite the mutations in their DNA. This leads to accumulation of mutations in future cells, which makes these individuals more prone to develop cancers, such as leukemias and lymphomas, especially after exposure to ionizing radiation, like X-rays. And that right there is a high-yield fact. Now, some cells with damaged DNA will simply die, and this can especially impact the nervous system. When the cerebellum's affected, which is the part of the brain that coordinates movement, it atrophies, leading to ataxia or difficulty with coordination and movement. In terms of symptoms, ataxia can first manifest in infants or toddlers as a delay in reaching certain developmental milestones, such as sitting or walking. As these children grow up, they can present with frequent stumbling or an unsteady gait, and trouble with fine motor movements like those needed for writing or eye movement. In addition, individuals can have difficulty with speech or swallowing, which can cause aspiration pneumonia. That's where bits of food or liquids are able to enter the airways and cause direct damage as well as infections in the lungs. Now, a high-yield fact here is that these individuals may also develop recurrent infections, especially of the respiratory tract, because of the defects in B and T cell development. Last but not least, for reasons we don't really know, most individuals affected by ataxia telangiectasia develop telangiectasias, also called spider angiomas. In a test question, look for a picture with dilated blood vessels visible, especially on the sclera of the eyes. Diagnosis of ataxia telangiectasia can involve laboratory tests showing lymphopenia or low lymphocyte count, as well as a low level of serum immunoglobulins, especially IgA, although IgG and IgE levels may also be reduced. In addition, for unknown reasons, these individuals may have a high level of a protein called alpha-fetoprotein, or AFP for short. Finally, diagnosis can be confirmed via genetic testing for mutations on the ATM gene. There is no cure for ataxia telangiectasia, so treatment is aimed at managing symptoms and complications. For reducing the risk of infections, immunoglobulin infusion and antibiotics can be used. For ataxia, in some cases, beta blockers can be used, as well as physical and speech therapy. And finally, individuals should have increased surveillance for cancer. Moving on, there's hyper-IgM syndrome, which can be caused by a variety of genetic defects. Now, the most common and high-yield one is an X-linked recessive mutation of the CD40 ligand, which plays a major role in communication between B and T cells. Normally, when a B cell comes in contact with an antigen from an invading pathogen, it will start producing IgM antibodies against that specific antigen, while also internalizing that antigen and presenting a piece of it to a T helper cell. That T helper cell then expresses a protein called CD40 ligand on its surface, which attaches to a receptor on the B cell surface called CD40. As a result, the B cell is stimulated to undergo antibody class switching. This is when the B cells switch from producing IgMs to producing IgAs, IgEs, or IgGs that will target the specific antigen. In hyper-IgM syndrome, there's a deficiency of CD40 ligand. As a consequence, B cells are unable to undergo antibody class switching, meaning that they can produce IgM but struggle to produce other types of antibodies. Now, because IgM isn't as efficient as the other antibody classes in fighting off infections, individuals with hyper-IgM syndrome are predisposed to infections by opportunistic pathogens, including fungi like Pneumocystis jirovecii, protozoa like Cryptosporidium, viruses like cytomegalovirus, and encapsulated bacteria like Streptococcus pneumoniae. Because of this, a high-yield fact that you should know is that the first symptoms that typically appear during infancy are recurrent episodes of pyogenic or pus-producing infections that most often involve the respiratory tract, causing sinusitis, pneumonia, and otitis. The diagnosis of hyper-IgM is based on laboratory studies, which show drastically low levels of IgG, IgA, and IgE antibodies, along with normal or elevated IgM levels. In addition, a lymph node biopsy would show a lack of germinal centers, which is where CD40 activation of B and T cells normally takes place. Finally, genetic testing can confirm that there's a mutation in the gene coding for the CD40 ligand. Treatment includes prophylactic antibodies to prevent infections, as well as immunoglobulin infusions which provide passive immunity to help fight off pathogens. In some instances, a bone marrow transplant can be done to establish a normal immune system. Last but not least, there's Wiskott-Aldrich syndrome, or WUS for short, which is an X-linked recessive disease caused by a mutation in the WUS gene. This gene codes for the WUS protein, or WASP, which normally is expressed by hematopoietic cells like leukocytes, and it allows them to reorganize their cytoskeleton. This is necessary for various cellular activities like cellular division, phagocytosis or swallowing up of foreign pathogens, and for communicating with other cells throughout the body. So individuals with Wiskott-Aldrich syndrome have an impaired immune response and are more prone to recurrent infections. The infections are classically due to encapsulated bacteria, such as Streptococcus pneumoniae, Haemophilus influenzae, and Neisseria meningitidis, opportunistic fungi like Pneumocystis jirovecii and Candida albicans, as well as viruses such as Molluscum contagiosum, Varicella zoster virus, and cytomegalovirus. In addition, the impaired immune response can cause an inflammatory skin disorder called eczema, which is characterized by dry, itchy red patches on the skin. And finally, you must know that the impaired immune response in WUS can often lead to the development of autoimmune conditions, such as autoimmune hemolytic anemia or idiopathic thrombocytopenic purpura, as well as cancers like leukemia and lymphoma. Another type of blood cells that rely on the WUS protein are platelets, which originate from a large precursor cell called a megakaryocyte. Normally, the cytoskeleton of the megakaryocyte changes shape, so that small cellular fragments can detach, giving rise to platelets. The platelets then go off to form clots at damaged sites to stop bleeding. In Wiskott-Aldrich syndrome, megakaryocytes are less able to form platelets, and the platelets that are made are small and fragile, so it's called microthrombocytopenia. In addition, these defective platelets are removed from circulation by the spleen, leading to even lower platelet counts. Typically, the initial symptoms include easy bruising and petechiae, which are small, red or purple spots caused by minor bleedings that leak into the skin. Additional symptoms can include bleeding from the nose, mouth, and gums, as well as bloody diarrhea. And that is a high-yield fact. To help you remember the classic triad of symptoms in Viscott-Aldrich syndrome, think of water. Viscott-Aldrich, thrombocytopenia, eczema, and recurrent infections. For diagnosis, the initial workup includes a peripheral smear, which would show the microthrombocytopenia. In addition, for unclear reasons yet again, remember that laboratory studies can show an increase in IgA and IgE antibodies, and normal or decreased levels of IgM and IgG antibodies. The diagnosis is then confirmed by genetic testing revealing the mutated WAS gene. Treatment of WAS includes prophylactic antibiotics, regular immunoglobulin infusions, platelet transfusions in the case of severe bleeding, and potentially surgery to remove the spleen, which can help to maintain platelet counts. Finally, the only cure involves getting hematopoietic stem cell transplantation. Alright, as a quick recap, SCID is the most severe form of primary immunodeficiencies. Most cases are caused by an X-linked recessive mutation involving the gene coding for the IL-2 receptor gamma chain. However, some cases are autosomal recessive, including ADA deficiency and RAG mutation. SCID presents in infancy with various infections and is diagnosed through screening tests showing decreased or absent TREX in blood, or based on low total lymphocyte count on blood tests and a low percentage of T cells in flow cytometry. For treatment, hematopoietic stem cell transplantation is recommended before the age of 3 months. Ataxia-telangiectasia is an autosomal recessive disorder caused by a defective ATM kinase, resulting in an increased risk of developing cancers, especially after radiation exposure, as well as atrophy of the cerebellum leading to ataxia, telangiectasias on the sclera of the eyes, and immunodeficiency due to a decrease in T cells and immunoglobulins, which shows on laboratory tests. There's no cure for ataxia-telangiectasia, so treatment is aimed at managing symptoms and complications. Hyper-IgM syndrome is characterized by a defect in the ability of B cells to undergo antibody class switching. The most common cause is an X-linked recessive genetic defect of the CD40 ligand. Affected individuals experience recurrent infections with opportunistic pathogens and encapsulated bacteria, and it may require treatment with antibiotics and immunoglobulin infusions. Finally, Viscott-Aldrich syndrome is an X-linked recessive disease caused by a mutation in the gene coding for WAS protein, which is produced by hematopoietic cells. The classic triad of symptoms includes microthrombocytopenia, repeated infections, and eczema. Treatment can include antibiotics and immunoglobulin infusions, as well as platelet transfusions, surgery to remove the spleen, or hematopoietic stem cell transplantation. Okay, back to our cases. Aurora is an 18-month-old girl that has frequent respiratory and ear infections, and her laboratory results reveal low lymphocytes and immunoglobulins. These findings should make you think that she has some form of immunodeficiency. Aurora also presents with scleral telangiectasias, milestone delays of speech and walking, and high alpha-fetoprotein levels, so diagnosis of ataxia-telangiectasia is very likely. On the other hand, Matthew is a 16-month-old boy who also has frequent respiratory tract infections. Unlike Aurora, however, Matthew's laboratory results revealed high levels of IgA and IgE immunoglobulins. In addition, he has microthrombocytopenia, which is probably associated with his frequent nosebleeds. This already should make you suspect Viscott-Aldrich syndrome. The final clue is the eczema, which completes the classic triad of symptoms. In both cases, genetic testing confirmed the suspected diagnosis, revealing mutations in the ATM and WAS gene respectively.